Good afternoon. Welcome to another Live and Learn. This is Bill Coast from Blanchard Valley Health System. We're really excited today to share with you another one of our episodes related to breast cancer. If you remember the last two sessions that we've had, we've talked about some of the things we do here. We have a guest with us today from the Mayo Clinic. We're going to be talking to her about what's going on with breast history prevention, as well as I have Dr. Derek Thomas that's going to be here to present some of the things we're doing at the Arms Center. Our objectives today are to talk about that history, to talk about what's happened in breast care, what we're able to do here, and then how we collaborate with the Mayo Clinic, which is one of the things that we've been doing over the past few years. So I thought maybe the way we'd start today with a couple of announcements. If you do have any questions, I'll put them in chat. We will try to answer those as we go. And we will have time at the end if needed. We always appreciate your feedback. We'll be doing a survey, or we'll be doing a survey when we finish. And maybe we'll start by having introductions. So Dr. Pruthi, why don't you tell us a little bit about yourself? How'd you get interested in what you're doing, what you do now? And then I'll have Dr. Thomas do the same thing.
Great. Thank you, Dr. Koss. And it's a pleasure to be part of the Live and Learn series. And I'm a consultant in the breast clinic at the Mayo Clinic in Rochester, Minnesota. I have spent the last 28 years working in a breast center. My primary interest has been managing women at high risk for breast cancer, women with genetic mutations, and I also practice in cancer care, so women newly diagnosed with breast cancer. My research interests have been primarily in preventing breast cancer, and I have led several clinical trials at Mayo Clinic looking at biomarkers to detect who is at higher risk for developing breast cancer, but also the use of prevention drugs and lifestyle factors to prevent breast cancer.
Thank you. And Dr. Thomas, how about telling us a little bit about yourself? One of the things I'm proud of is being able to help recruit you here, and we're glad to have a local boy come back. Tell us a little bit about yourself, Derek.
Thank you, Bill, and certainly glad to be here. So again, my name is Derek Thomas. I'm a medical oncologist and also a hematologist. And I've been here at Blanchard Valley now for 6 going on 7 years, and came here from my training. And I am from the area, born at Blanchard Valley 40 years ago, and made my way back. So I made a little pit stops in Dayton. I did my medical school as well as my undergrad, both at Wright State University, and then over in Indianapolis, which is where I did my residency, a chief residency year, as well as my medical oncology and hematology fellowship, which was at Indiana University. And always knew I'd want to come back. I like the area here, so what wasn't a tough sell to get me to come back here, and enjoy being back here in Findlay as well.
Well, we're really glad to have you here. So Derek, from your standpoint, the big picture of why do we want to talk about breast cancer, and what are some of the things that we're doing here locally?
So, first, it's hard to find somebody that hasn't, heard or known somebody to have breast cancer. And it's because it's, become so prevalent, and a little bit of, sobering statistics, but also some positives in the field certainly as well too. So, breast cancer is the most common cancer that's diagnosed worldwide outside of superficial skin cancers. And for women, 1 out of 3 women who are diagnosed with or hear the word cancer, it will be breast cancer. If we look just at the US, 1 out of 8 women in their lifetime will be diagnosed with breast cancer. So again, it's just hard to find somebody who hasn't been touched by this disease. If we look at US statistics, there's each year, or this year, estimated 297,000 women diagnosed with invasive breast cancer. And so again, those numbers are pretty staggering, but it's not to say that we haven't made headway, and the death rate is clearly decreasing from breast cancer. And that peaked at around 1989, and there's been a relative 43% reduction in the death rate. So when we're diagnosing more breast cancer, more women are living longer and being diagnosed with breast cancer, and the death rate's lower, the prevalence is just increasing. And so there's 3.8 million women in the US living with their breast cancer or surviving their breast cancer. And so again, very, very high numbers. but treatments are certainly improving. To look at a little bit more closer to home locally, what are we seeing trends-wise in breast cancer? And the local statistics are very similar to what we've seen in the state and national levels, and around 125 women per 100,000 are being diagnosed per year in Hancock County. And that's very similar to what we're seeing national and statewide as well, too. As far as our diagnostics here in our local data, in 2023, as of about a month ago, we've seen 94 new cases of breast cancer. And over the last several years, we've averaged 121 per year. And that's the number of breast cancers we're taking care of here locally in our center. And so that represents about 20% of all of the cancer cases that we're seeing here at the Arms Cancer Center. And in my practice, I see a bit more of the breast cancer, and I would estimate that probably somewhere between 40 and 50% of my caseload is breast cancer. So we're taking care of a lot of women here in Findlay.
So certainly from a standpoint of volume, it is something out there. So Dr. Pruthi, how do you look at this from a standpoint of, well, we've got a lot of volumes. Are there messages we want to talk to women about prevention, about lifestyle, about things like that? And how do you talk to people about that?
Yeah, that's a great question, Dr. Koss. It's a lot of it today, and talking about just going back to Dr. Thomas describing the large numbers of women who are going to be diagnosed with breast cancer. There are just as many women who are high risk because of a family history of breast cancer, and those are the patients who we want to be able to prevent breast cancer and early detect. And I teach and counsel my patients about the importance of what they can do to be able to catch a cancer early, detect a cancer early, and the importance of screening mammograms. And we follow there are many guidelines out there, and at Mayo Clinic, we follow a guideline that the American Cancer Society recommends, is that all women should start screening with mammograms at age 40 yearly. But there's more to just screening. There's a component of early detection that includes breast self-awareness. This is a new term that is different from breast self exams that were done previously. For years, we would tell women to do a formal technique to detect for cancer. And it's really down to now being more comfortable and familiar with what's normal on your breast exam. And if you were to feel something different or something new that's not been there before, and you noticed it, not to depend on a normal mammogram, but to get that checked and evaluated by your doctor promptly. That is also extremely important in early detection, is our own self-awareness. But we are asked often by patients, can we prevent breast cancer? And we're fortunate that we've studied, and the literature supports a lot of new ways in which we can modify lifestyle factors that have been known as risk factors for developing breast cancer. And it's very important that patients know that they can do something such as exercising, at least walking 30 minutes a day, watching their weight, and alcohol in moderation, one or less alcoholic beverage a day. All these factors, if excessive use of alcohol, weight gain, lack of exercise, do contribute to breast cancer risk. Why not make the efforts as those things that we can control and modify in our own lifestyle to prevent breast cancer? But there's more, and we're looking at new medication options that very high-risk women could consider taking to cut their risk of breast cancer down. And this is where, more now than ever, it's important that our patients are getting breast cancer risk assessment. We want our patients to come in and see us, to meet with our doctors in the breast center, to talk about risk and assessment, taking into account the family history, any other risk factors they have, and helping personalize and individualize what are we going to do to prevent breast cancer, and if they're high enough risk, is there a role for preventive medications?
Yeah, it's really interesting. I was just doing a little research. I didn't realize that you talked about walking. That I like to walk, and men can get breast cancer too, if I'm not mistaken. That there's really good data to say just what you said. Again, for everyone that's out there, getting out and get some clean air and all that is good to start with, but it does reduce the amount. Is there any theoretical reason for that? Does it change estrogen levels, or why would exercising or eating, let's say, a Mediterranean diet make any difference
Right.
theoretically?
Theoretically, sure. So, obesity, adipose tissue is actually a source of estrogen. And we metabolize estrogen in our adipose tissue. And one of the risk factors we know, one of the most common breast cancers are hormone feeding breast cancers that depend on estrogen. So that's where exercise contributes to managing weight and can help reduce the risk of estrogen to feed the growth of these hormone feeding breast cancer cells. So that's important, and that's sort of the theoretical risk behind exercise as well as weight, maintaining a healthy weight.
And one of the questions that's already come up, we'll just take now, is from a high risk, where does genetic testing come in as far as, let's just say, routinely? Who should we be thinking about prioritizing for that?
So that's a great question, and I think the most important thing we can do is take a really good family history. We want to know who was affected with breast cancer in your family, what age were they diagnosed, what types of cancers were they diagnosed with. We use this information to then decide that there's enough family history here that requires meeting with a genetic counselor who could then pursue the next step of ordering the appropriate genetic testing. They're called panel genetic tests today. That means it's more than just BRCA1 and BRCA2, which we've known for years has the most common genetic mutation associated with breast cancer. But now there are many more genetic mutations. So taking a good family history, if you know your family history and you know there are significant family affected young onset relatives with other cancers other than just breast, ovarian, or colon, or melanoma, or pancreatic cancer, talk to your doctor, and will make that referral to a medical genetics counselor who will then take you through the decision about what test to order and when to order genetic testing.
We just had a question, and this would be about prevention. I'm looking about things that was a common question that I've heard. If I've been on birth controls, or if I'm not on birth control pills or estrogens, you want to high level again about the prevention
Sure.
and what people should be worrying about.
Yeah, we get that question a lot. So there is some data that even the newer generation birth control pills, there's a very small risk, like 1 in 100,000 who could get breast cancer from using birth control pills. So fortunately, it's a small risk. And for that reason, I do not tell patients they should not use birth control pills if they are indicated for medical reasons or for family planning. Even in those who have a family history of breast cancer, it is safe to use oral contraceptive pills.
Thank you. So Derek, you've heard this is okay. We got the world's experts, the biggest brand in healthcare we're talking to. Does this comport with what we do? How does the Arms Cancer Center and Hancock County medical staff look at these kind of things?
So I think the biggest thing that Dr. Perthy said that I just want to keep on is prevention. And as being a medical oncologist, the vast majority of patients that I'm seeing are for diagnosis of breast cancer once diagnosed. But to really move the needle forward and have better outcomes is, can we find these cancers earlier? Can we detect them at an earlier stage where we'll have better outcomes? And then even going a step further, can we prevent the cancer too? So really exciting, the data that Dr. Perthy's alluding to and the studies that she's been involved in too, to look for ways of preventing breast cancer. And I do see some patients for medical prevention of breast cancer. They're usually taken by referral who've met a high risk criteria. But to be very fair, that is very underutilized. And so we do have several FDA approved options to medically reduce the risk of breast cancer for high-risk individuals. And this is something that we need to increase awareness for, and then increase awareness for our general referrers and our primary care physicians, and increase that potential option. Now, it doesn't mean that everybody should get these options, and it requires a risk-benefit discussion with those patients. But yes, prevention is key. And here locally, again, we certainly want to prevent. And if I can avoid seeing these patients with a diagnosis of breast cancer, that's all the better. And so as a cancer center, I think it's our job and our role to the community to not only, one, try to improve the care of patients with cancer, but what can we do to improve our community's risk of breast cancer, patient education, provider education. And so we're involved with health fairs, patient education, quality improvement protocols. And we do look at it as taking care of the community, not just taking care of our patients. So there's a lot of different ways that we as a cancer center are trying to integrate ourselves into the community to try to better the outcome of patients with breast cancer.
So let's say the approach at ARMS, how you look about this, I know part of it is a team approach, that you have different individuals. You want to speak to that a little bit about if someone had a question or if they come out for consultation, what's the process that you go to either make a diagnosis or to give a good advice?
Sure. So when a woman's diagnosed or has a suspicion of breast cancer, typically, and the vast majority of them are on a mammogram, whether that be a routine screening mammogram, which is hopeful that we're catching at an early stage without symptoms, or whether they've developed a lump or a symptom and they go in for what's called a diagnostic or a more involved study, diagnostic mammogram and an ultrasound and such too. But once there's a suspicion of breast cancer and a biopsy, what we learn, and especially once there's a diagnosis of breast cancer, is that patients are thrust into this world of breast cancer, and it's really overwhelming. And it's a wealth of information that's thrown at them very quickly. And then also a lot of treatment teams, including a medical oncologist, such as myself, a surgical oncologist who is their breast cancer surgeon, oftentimes a radiation cancer doctor, but then also all these other teams for support, which are really important. And the collaborative team approach is important, but it can be really overwhelming. And so locally, we've adopted, and most cancer centers have as well, of what's called a nurse navigation model, which is where from the onset of diagnosis, each patient is established with one of our oncology nurses who their full-time position is as a navigator. And their job is to be a point of contact to help them navigate this complex process and be an intermediary between all of these different treatment teams. And one thing that's been really refreshing coming back here to Findlay, and I think it's really difficult to grasp what this is going to be like in practice, especially when you're in training and learning from individuals. And coming back to Findlay, one thing that I've been really, really happy to see is that how well we collaborate as a team. And being a small community, you really get to know the different people you're working with. So the surgeons, the radiation doctor, myself, but also our support staff here at the Cancer Center. We all know each other very well. We're bouncing ideas off each other. I can't tell you how much benefit that, whether it's our dietitian, our nursing staff, our infusion staff, giving me an idea, hey, this patient's, having an issue or having a struggle. And that kind of communication is worth its weight in gold as far as improving the outcome. So the collaboration and communication is key to maximizing a good outcome in breast cancer. And again, it can be very overwhelming for the patient to have all of these individuals, but it really takes a comprehensive approach to maximize the cure of breast cancer.
So Derek, from a standpoint where you talk about the team, one of the things and we're talking about the early diagnosis, so that's mammography. I'm going to ask Dr. Pruthi in a minute about, I think at least if you go out and search the internet, how often should I get a mammogram? So I'll let you answer that data. What we do at the ARMS is we've got a person that's out there, a radiologist, that is what she is doing, is looking at this. So we're pretty lucky to be specialized, to have those capabilities to be able to do that. And if you want to, I'd like to have both of you comment on the use of 3D. I mean, that's been something that has changed over time, and women have heard, I'm sure, all kinds of stories about radiation and things like that, that the safety of mammography and why the importance of 3D, if both of the two of you would comment on that. Derek, you want to start first?
Sure. So to answer your first question, how often should I get a mammogram? The easy and quick answer would be, according to guidelines for a standard risk woman, according to American Cancer Society, American Society of Clinical Oncology, United States Preventative Task Force, would be annual or once a year, getting a mammogram once a year. Now, there can be some nuances to that as far as exceptions. When would we suggest more advanced testing and integrate more often than once a year testing? And there's certain very high risk individuals who may have different suggestions. So again, going back to something Dr. Perthy said very importantly, is not taking, even though guidelines are set up to set a standard option, is it's not always a one size fits all though. And we need to look at each patient differently. What is their risk? What's their individual risk? And what's their recommendation? But to answer a bit more simply, a standard risk woman, we would recommend once a year annual mammogram. The majority of our mammograms are done at every center are offered our tomosynthesis, which is the fancy name for 3D mammogram for those that have heard of that. And for 3D mammograms, the data for that have shown that there are less what are called recall rates, which is where we have to come in for further testing to say, hey, we saw something, we're not sure if it's significant or not, but we just need a better look. So there's less recall rates and there's a better sensitivity to that, or the ability to diagnose or be confident with the diagnosis of breast cancer too. So in my personal opinion, although I definitely want to get Dr. Perthy's opinion on this too, is I don't see a situation where it's not an ideal or a recommendation to get a tomosynthesis or 3D mammogram. And that's what I'm recommending for all of my patients or families or friends that are getting their screening mammograms.
Is that, before I turn it over to Dr. Prithvi, is that an insurance issue? I mean, and I don't know the answer to that we would, if that's the best test, that's what we routinely ought to be doing. In general, are these all accepted, as far as you know, by insurances now? You don't have to get pre-authorization or anything like that, this is the common way that we look at early detection.
Yeah, I have not seen that to be an issue as far as insurance or coverage. And maybe initially when the technology first kind of became adopted, perhaps maybe, but since I've been in practice, I've yet to see a mammogram have any insurance coverage issues, including tomosynthesis and 3D mammogram.
Thank you. Dr. Prithvi, you want to comment on those?
Yeah, I agree with everything Dr. Thomas said about the importance of starting at 40 and annually, but especially in younger women where there is this concept of dense breast tissue, younger women who are still menstruating, making the hormonal changes with their cycles, makes the breast tissue more dense, and mammograms can be difficult to interpret when you're younger, and that's why the 3D mammogram, as Dr. Thomas said, is what we are recommending, especially in their 40s and 50s. As women age and over time, the density does get less. It's just like normal aging process, the milk glands shrivel and get replaced by fatty tissue. The mammograms get less dense. Then over the years, maybe you don't need a 3D and you could go to a 2D mammogram. But there are studies underway right now comparing 3D to 2D mammography in terms of sensitivity and in being able to detect cancers. But in general, I would recommend a 3D mammogram. Now, the other thing that I want to remind people, because of the density on a mammogram, you are now seeing in your reports from your radiologist that they are telling you what your mammogram density is, for two reasons. One is to remind you that if you have dense tissue, you may need additional, we call it supplemental imaging with breast MRI, and Dr. Thomas mentioned that those imaging tests would be then ordered based on an individual basis, based on your risk. And in those scenarios, you would get both a mammogram and an MRI, sometimes alternating every 6 months, one of the tests, and then with the other MRI every other month, every other 6 months, or you do both at the same time. Again, this is personalized. Your doctors will help you decide which is the right frequency and which of the tests you should be getting. I do want to add one more thing, that this is again a reminder that if I'm talking about dense breast tissue, those are sometimes harder breast exams as well. And that's when we can miss a cancer. And the breast exam is just as important, because if you felt something different on your own breast tissue thickening or lump or some changes, and your mammogram is normal, then that's when you're going to need that diagnostic imaging. You're going to want to come back and talk to your doctor about getting an ultrasound if needed to further evaluate that area, because we can miss cancers in dense breast tissue, even on the mammogram.
Good point. And that certainly does occur. Let's switch gears a little bit and talk about treatment. One of the questions that came through chat is, if I have breast cancer, do I need to get chemotherapy? The part B to that usually is, does that mean I'm going to lose all my hair? At least that was the questions that I got. So Derek, you want to talk about things have changed, and I'm not going to editorialize. When I was a medical student, if you had breast cancer, you had a radical mastectomy. Those things have all changed over the years of what we do. Do you want to talk a little bit, Derek, maybe just about philosophy? I know you can't cover everything, both of you, but we have a team approach, we have tumor boards, we have algorithms, we have all kinds of data. Just kind of speak to what a woman ought to hear, because the last thing we want is someone avoiding coming in to get diagnosed because they're scared about what can happen. There's been really big changes. So Derek, make some comments, and then we'll see what Mayo says about that.
So sure, and you're right. There has been a lot of changes in breast cancer, and I still consider myself young. I've again been out of training for 6+ years, and even in just that time frame, we've seen some changes in this as well. And one of the big changes in breast cancer has been what we would call de-escalation, pulling back on therapy. And that's really exciting and really good to have that information and data. And when I meet with a patient that has a new diagnosis of breast cancer, that the intent is to cure, so localized breast cancer, I often say there's 2 goals for most patients, and we're going to walk through what your goals are. And goal number 1 is that we've heard this word cancer. What can I do to maximize my cure rate? But also goal number 2 is, and we don't always think about this, what can I do to minimize the risk to me? And those are very important, and to weigh those bothly. And what we've learned is we've got a lot of great tools, in that most patients with breast cancer that is localized, that's diagnosed, will be cured of their cancer. But we can also treat too aggressively, where we can cause harm with treatments that maybe weren't needed. And that's where the chemotherapy question comes in. Do all women with a localized breast cancer need chemotherapy? The quick answer would be no, because we know a lot of women maybe have an equivalent cure rate without chemotherapy. And that the exactness of preciseness to be able to determine whether or not someone needs chemotherapy has gotten so much better, even just in the last 5 years. And for the most common type of breast cancer, which would be a hormone-driven breast cancer, which is what Dr. Pruthi alluded to, most women that are diagnosed with a localized hormone-driven breast cancer will not get chemotherapy. It does have a role for some women to improve the cure rate, but where the data has gotten really excited is more personalized medicine, learning more to really dig into the nitty-gritty of the tumor and look at molecular changes or mutations within that person's individual tumor that can predict the chance of it coming back, but also predict the benefit or lack of using chemotherapy. And we can actually be quite precise now in informing women that we are not leaving anything on the table by omitting chemotherapy. And that's great for 2 reasons. Number 1, it can give us great confidence in those recommendations. But 2, it can reassure the woman that I've got an excellent chance of beating this cancer, and I'm not sacrificing anything by not getting chemotherapy. And in fact, over time, we've learned we've overtreated breast cancer, not rightly or wrongly, but because of what we knew. And we've been able to de-escalate or pull back from that treatment and still achieve better cure rates, which is really exciting, to treat people less aggressively, put them through less hardship, and still have a better cure rate.
Thank you. Dr. Pruthi, you want your thoughts?
Yeah, I really like the way that Dr. Thomas talked about where things have changed with de-escalating therapy. Not everybody who gets breast cancer, even the invasive cancer, will get chemotherapy. And the reason that we're here today is because we've gotten so much better at understanding the biology of the breast cancer. We know what kind you have, the type. We're able to know if they're the hormone feeding kind or not the hormone feeding kind. There's another marker called the HER2 positive. These are markers that are helping us say, is this a more favorable, good prognosis cancer, or is the markers are telling us that it's a more of a unfavorable tumor or more of a cancer that's more aggressive. And knowing that up front, you are better able to target the right drug for the right patient at the right time. And that's exactly what Dr. Thomas has described as we've watched how cancer care has gone. And we're fortunate that we're able to do that today much more personalized around the patient's type of cancer. So I always tell my patients, they're like, but my aunt had this. And I'm like, we don't know the biology of your aunt's cancer. So let's not talk about your aunt's cancer. Yours is like this. And these are the features your cancer is presenting as. And for this reason, we can target specific medicines that we know work. So we're in a much better place now than we were years ago in treating breast cancer.
Yeah, that's a great point because of all the data and those kind of things. Let's talk maybe a little bit, Derek, about the relationship with Mayo. How does that work in practicality, and let's say also in theory about where we get our data and the algorithms? I have the opportunity. I've listened to tumor boards both at Mayo Clinic and also that we meet about every 2 weeks to go through all kinds of cancers. Maybe you can talk about this again. It's reassurance to the public that this is something that's really vetted by a lot of people. You talked about our team as to how look at it, and then it becomes an individual, as Dr. Pruthi said, an individual treatment plan. Everybody is different, but there's been a lot of input into that to make that decision. So Derek, if you want to maybe expand a little bit on that, but then how and when is the collaboration with Mayo something that we use? And I'll let her respond to that too.
Sure. So, a few years ago when Blanchard Valley developed this clinical collaboration with Mayo Clinic, it was really exciting too, because it basically has given us just more tools to be able to do the job that we're already doing. And obviously we have Dr. Pruthi here today through Mayo Clinic and available to give her expertise today. But we're using this in our clinic as well too. And just a few of the options, because there's a number of ways that this collaboration has kind of manifested, but a few of the ways that I'm using it personally in my clinic or that my patients are seeing this collaboration. So one is what's called a e-consultation or electronic consultation. And so we're able to have basically a case ran by a Mayo Clinic doctor, cost-free to the patient, without the patient having to leave their home, travel to Rochester, and really get the expertise from a breast cancer specialist, or other cancers as well, but a breast cancer specialist for breast cancer purposes, right in the comfort of here in Findlay. And so when we do that, we're submitting all of their medical records correlating with their disease. And so it'll include even their pathology, the documentation from our discussions, any of their scans or imaging, including the mammograms, for an expert team to review and a medical oncologist to review and give their expert recommendations. And where I see the benefit for that, and where the patients see the benefit of that, is number one is peace of mind. Hey, we're all in this together. We're a collaborative team, not even just our team in Findlay, but our team in Findlay and Mayo Clinic. And we think this is the best treatment for you. Where I find it helpful as well too is there's sometimes very challenging cases, and cases where maybe there really isn't a right or wrong answer, or and not a clear-cut standard of care answer, and clinical judgment plays a huge role, and really relying on experts that have a wealth of experience can be quite beneficial. Some other ways that we use this collaboration is, I think you were referring to, is these algorithms, and there's a program called Ask Mayo Expert, where Mayo Clinic uses this internally, and it's basically an algorithm of standard practice and up-to-date care that kind of walks through a diagnosis and the appropriate testing and standard of treatment. And this is what their doctors are using to kind of sit at the bedside with their patients and make treatment decisions. And we have the direct access to that as well, too, at any point in time, right through the computer screen. You made mention of tumor boards. And essentially, for those that don't know what a tumor board is we have, again, every other week meetings here in Findlay. We're doing them electronically now that involve all of our members of the cancer treatment team, the physicians and treating physicians. And so this can include medical oncologists, surgeons, radiation oncologists, also pathologists and radiologists. And cases that are challenging or cases that are interesting that we can learn from one another, we're presenting those cases where we're looking at the scans, looking at the pathology, discussing treatment options to come up with a cohesive team-based approach plan. And that can be very beneficial too for some cases that are challenging. Mayo Clinic also does tumor boards, and they have tumor boards specifically for breast cancer. And through Mayo Clinic, or through the Mayo Clinic collaboration, we have the ability to actually join their tumor boards, and we can actually even present cases at their tumor boards. And I've done that a few times over the past years for really challenging cases that we're looking to even bring in extra expert opinions. It's also good for education. I can watch their tumor boards and learn from their cases and how they're treating patients and keep up to date with, the most standard, treatment options too. So it's been a refreshing, nice option to just have in our tool belt to be able to use to maximize the best care for our patients.
Dr. Pruthi, from your standpoint, relationships with, let's just say, community hospitals in general and things like that, anything you'd like to add to that?
I really think that this collaboration partnership, which is the Mayo Clinic Care Network, is exactly what Dr. Thomas just described. We want patients anywhere in the country who are experiencing a new cancer diagnosis or have questions about their care to be able to go and be able to stay locally in the comfort and close to their community, their family and their friends, and in their own cities, and where they can still have that, but leverage the expertise of Mayo Clinic when they need that extra recommendation or insight that Dr. Thomas described through these various electronic consults or tumor boards, and allowing that patient to get access to that information without having to leave home and still have their care delivered and received closer to home. And that's the perfect match of what you could expect from a Mayo Clinic Care Network collaboration. And I know that Blanchard Valley Health System and what Dr. Thomas is doing every day is using this collaboration to make their patients get the best health care and experience that they can get done locally.
So if one of our providers, well, let's say, or I can let Dr. Thomas say, but if he had a case, then we prepare the chart and we send those to someone from Mayo. It may be a surgeon, it could be in any, and this we're obviously talking about breast care. And then there's an evaluation that's done and it's transmitted back to the attending physician. This would be your opinion with the information that we supply to you. Is that the way it works? Would that be fair to say, Derek?
Yep. So, essentially from my end, what I end up seeing back is I request what kind of doctor I'm looking for the expertise. It typically does involve somewhat of a multidisciplinary approach. A lot of times they may have a pathologist review the pathology. They may have a radiologist re-review the imaging just to ensure all of the information is as accurate as possible. And then the communication will be directed back to me from that provider of whether it be a medical oncologist, a surgical oncologist, a radiation oncologist, to me. One thing that has been nice to see over this time too, and in certain situations, if there requires clarification, is it does require us to provide a means of communication too. And not uncommonly, I might get a phone call from a doctor at Mayo Clinic to say, hey, I'm looking through this. I'm just going to put my note in and share this with you. But here's some of my thoughts. I wanted to convey this directly. Or, hey, I have this question about this. What did you mean by this? Or what exactly or is here so that I can make the best recommendation? And so I've got to talk to a number of doctors at Mayo Clinic, even directly in that fashion, again, to help the patient's care.
And one of the things I'll say to all of our audience, this is something that is covered by part of our relationship in the network. And so there's not a charge to the patient. And the emphasis was on good quality, obviously, to start with the best kind of care, but to be able to keep people at home. And it has worked out well. We've had testimonials, good feedback from patients where this has occurred. Well, I think we have covered our what I wanted to make sure we got covered, but we do have some questions. So Jen, do you want to, and we'll, let's see what our consultants think.
Sure. So one of the questions that came in was relating back to the possibility that males could also have breast cancer. So one of our attendees had asked, how prevalent is male breast cancer, and are the risk factors the same as women?
Dr. Pruthi, could you hear that question okay?
Yeah, I can. Yeah, and I saw it come up. I really like that question. So 3,000 men a year in the United States will get breast cancer. Unlike the number that Dr. Thomas mentioned, women, 250,000 women will be diagnosed with breast cancer every year in the United States. So yes, a very small number, but when men do get a cancer diagnosis, the most interesting presentation is they felt a lump. And it was in the course of showering and dressing, just like I described for women. Men were saying, well, if women are doing exams, I'm going to do them too. And that's how I would ask my male patients when they were diagnosed with cancer. What brought your attention to it? Well, I was showering and I bumped a lump. I have a call coming in next week. I have a male patient said, I felt a lump. It's tender. And we would work him up just like we would in the case of a woman with breast cancer. We would recommend a mammogram. We'll recommend a biopsy, and we'll look at the pathology and treat them. And I'll let Dr. Thomas speak to it very similarly to women. But yeah, it does happen. Risk factors. Family history can also be a significant risk factor. The important thing in men, if they're diagnosed with breast cancer, is we like to do genetic testing to see if theirs was potentially genetically or inherited through a mutation. Because if a male has breast cancer, it can often be more often a genetic risk factor. And that's important for their daughters, their family members, because then we may want to test other individuals. And I will tell you how many times I've seen women in my practice who come to me and say, my father had breast cancer and he tested positive, and I went on to do the test and I actually carry the mutation. And what are you going to do, Dr. Pruthi, to prevent me from getting breast cancer? So men have a significant role to play here.
Thank you. Dr. Thomas, anything you'd add to that?
No, I think that was excellently put. I guess one thing to add would be, based on those small numbers, we don't have any data for role of screening testing, so we would not typically screen a male for breast cancer. But I think body awareness, and not just for breast cancer, but in general, be aware of our body. If something's not acting right, get in and see your doctor, and physician awareness too, that this is something that's out there. And even though we're a much smaller hospital than Mayo Clinic, I have several male breast cancer patients, so it is there. It's out there in the community. Again, much lesser numbers, but it's there. And then just the one of the struggles is that a lot of it is extrapolation of how we treat with female breast cancer, and we're really striving to learn better about underrepresented populations, including male breast cancer, and how does this work? What makes it drive to find out uniquely? Is it should it be managed differently? And there is a paucity of data for male breast cancer. There are some studies too, but we can still achieve good outcomes with male breast cancer as well. So earlier detection of an abnormality, earlier staging leads to better outcomes.
Great, thank you. Jen, another question?
Sure. Speaking of history of cancers in families, a patient or community member that has a strong family history with multiple cancers, are there specific markers that should be monitored more closely?
Start again with Dr. Pruthi if you want to comment on that.
Yeah, so I'm having trouble understanding what the question is about specific markers, but if you have a strong family history of multiple cancers, here's why you would want to meet with a genetic counselor to do what they would then look at the different cancer types and then determine what are the specific gene mutations that could be associated with that, and test for those markers, those genetic tests in your testing panel. So if somebody tells me they have a strong family history of pancreatic cancer, we know that there are other genes other than the BRCA1 or 2 gene that can be associated. Then we would test for other genes that could cause pancreatic cancer. So yeah, we would be monitoring you more closely for those genes if we knew what specific cancers you had. Dr. Thomas, is there any more you would add there?
Yeah, the only thing I wonder if they're might be also asking too, in kind of a correlate would be prostate cancer. We do have a blood test called a PSA that's very commonly and well known to be a marker that you can test for to help screen for prostate cancer. And we just don't have that equivalent in breast cancer. And so we have no data of any blood testing or a specific protein that would exist in breast cancer or DNA test that would exist in breast cancer that is known to improve earlier detection and screening. So we don't have that correlate. So again, the best data we have is for screening mammograms.
Thank you. Jen?
I just want to add one more thing. Thank you, Dr. Thomas, for describing that. We don't have specific markers, but some of the work we're doing at Mayo Clinic right now is a research trial where we're collecting blood to look at what we call common genetic variations, variants. They're called single nucleotide polymorphisms. We're looking to see if those early variations, if they're detected in the blood, might predict who is at higher risk of breast cancer, and potentially in the future to look at it for other cancers such as prostate or ovarian. So there is research underway looking at better markers. So I really like that question from that individual's perspective. Are they available today? No, but in the next few years, you will be starting to see potential markers that could help us detect who could be at higher risk of a certain cancer.
Thank you. Jen?
Sure. If a person has gone through breast cancer and received a bilateral mastectomy, what is the best way to monitor any return of the disease? Should an MRI ever be used?
Dr. Preeti?
Yeah,
It
so
looked like you were ready to answer
yeah,
this.
I like this because I see this every day in the clinic because I do take care of survivors after breast cancer. So after breast cancer, you've had a mastectomy, there is no role for screening with mammogram or MRI. For screening, that means looking for something new. We don't do any monitoring other than a breast exam, and we still recommend that a chest wall exam be performed to make sure there's nothing coming back like a lump under the skin. That is done by your doctor every 6 months for the first 5 years after the cancer diagnosis, and then yearly thereafter. Now, if somebody has felt something that's concerning and they have had reconstruction, and it may have changed on the exam and they're concerned about something new, then in that case, we would use an MRI if we needed it to look further to see if this is related to the reconstruction or is this a cancer recurrence, because there's a implant in place or tissue that an MR would be helpful there. But for somebody who's gone without reconstruction, there's no role for an MRI.
Thank you. Derek, just came up about reconstruction. So maybe could you make a comment about what we're doing? Kind of exciting what's being done down at Bluffton Hospital for our community hospital, some of the new techniques.
Sure. So we talked a lot about the collaborative care and individual teams that are involved with the breast cancer care. And one we neglected to mention was our reconstruction specialists. And so they're not necessarily involved with every breast cancer case, but in certain scenarios they may be. And this would be breast reconstruction. So in a patient who has a mastectomy, wants to look at options to retain breast tissue. And there's a lot of different options that can exist with that. And at times that can be very overwhelming too. So having a good and trusted plastic surgeon or reconstruction specialist who specialize in breast reconstruction can be an integral part of the team. And more recently, we've had now one of the physicians that works down in Columbus, a plastic surgeon breast reconstruction, who comes up to Bluffton to do some of those reconstruction surgeries. And we're not just talking about breast implants, we're talking about even natural tissue being transferred. And so they're doing some of these very complicated surgeries of tissue transfer from tissue from the abdominal wall, tissue from some other places as well too, and reconstructing breast tissue too. So it's an exciting time to be able to offer those options to women and have another, again, resource that can be closer to home as well too.
Thank you. Jen, any final questions?
We actually have one more question. Dr. Thomas had referenced millions of women who are, quote, living with breast cancer. Could you speak more about this and how medical advances have improved the possible prognosis for these women?
So we'll start with you, Dr. Thomas.
So, and to clarify a little bit too, and this was pulled from statistics too. When I'm seeing patients, I think labeling them as actually kind of where they are and their disease process and their journey is important, and kind of understanding where they're at. And there can be two different extremes. One can be women that are living with a metastatic breast cancer, and we know that patients are living longer with breast cancer with the advances in treatments, which is very exciting. And one of the advances I've seen, even again just since I've been here in Findlay, is that the treatments are becoming more numerous, but also more specific and more personalized for metastatic breast cancer. And patients certainly are living longer. Women who are treated with curative intent, so this would be a localized breast cancer is limited to the breast or the breast and lymph nodes, where the goal is to cure the treatment. That also goes into those numbers that I was quoting. And our hope is that they are disease-free. And so when I talk to those patients, I tell them I'm not going to use the word remission here, because my hope is you are disease-free. To my knowledge right now, you are disease-free, but I don't know that it couldn't come back. And so we watch those patients very closely for a period of time. And for a hormone-positive breast cancer, it's often an extended period of time. And even though the cure rates are high and they're getting better for a hormone-positive breast cancer, there is the possibility it could come back even beyond 5 years, into 10 years, 15 years, even have been seen up to 20 years later. And so those are patients that we really educate about what to look for, what to monitor for, not to live in fear, but to live educated and live kind of acknowledging of the possibility, so that they can get earlier assessments if there is a concern as well. So those patients I see much longer. And conversely, a cancer, like I'm just going to pick another cancer, like colon cancer. After 5 years of disease-free, the rate of recurrence is almost 0%. And so I turn them back over to their primary care and say, if there's any concerns, see me. But a lot of breast cancers we're seeing, we follow them longer. And so that would go into that number of living with breast cancer. Even though they're disease-free, we're monitoring them, we're following them longitudinally.
Dr. Pruthi, from a standpoint of the way Mayo looks at this, additional comments?
Yeah, I actually think it's not just the advances in drugs and the targeted medicines that were available now for the right type of cancer. And it's more even lifestyle. There's some great evidence out there that even among survivors after breast cancer and other cancers, that exercise, weight management, eating a healthy Mediterranean diet have all been shown to reduce the risk of recurrence, even for those hormone sensitive cancers, but even those triple negative cancers. So I think that it's just as important that those who are living with cancer or have had a cancer and are survivors continue to maintain those healthy lifestyle habits that they can control to continue to prevent a recurrence.
Thank you. Well, we're coming to the top of the hour. I really want to thank our two consultants, our speakers today. I think for all of you out there that you've heard that there's been a lot of changes in breast care. We can start with prevention. We can start with what the new diagnostic treatments and kinds of things are. It's going to be individualized. I think you've heard about our relationship with what we do with Mayo. We feel that has really been a strong affiliation from a standpoint of our healthcare system, but more importantly for our patients getting the best care. One of the things that's been emphasized is timeliness, that we're able to make these diagnoses and be able to talk to people. And again, we'll talk in the future. We appreciate all of you that have been on today. If you do have questions, you can send them to us. We'll try to get back with you. If you have ideas for our next Live and Learn, we appreciate that. We will be sending out a survey, and we thank you all for being with us. And again, I want to extend Dr. Pruthi and Dr. Thomas for taking an hour of your time. I think it was really informative, and I, as always, learned something. So thanks, everyone.
Thank you.
Thank you.